Robert, next year when you have a photograph of you, I'm sure everybody will be introducing a video of you doing something really weird. Anyway, so I'm going to talk about patulous eustachian tube. And because this is a middle ear conference, I decided to focus on the middle ear approach patulous eustachian tube because I've run a eustachian tube clinic for 10 years almost now with a rhinologist, and we've seen lots of patients with all kinds of patulous eustachian tube symptoms. I'm going to talk about a middle ear approach to the patulous eustachian tube. So anyway, classically, we often think of patulous eustachian tube as having an obstructive or a patulous component. So there can either be negative pressure or there can be, autophony, hearing your voice, hearing your breathing. But I'm here to tell you that they can often be interchangeable. So a lot of the symptoms that we have of negative pressure can be caused because people have symptoms of patulous eustachian tube. So they hear their voices in their ear, and they do maneuvers such as sniffing or vacuuming that ear to try and empty it. And that can also lead to negative pressure. Also, sometimes we find that they go back and forth. We see patients who have symptoms of hypofunctioning eustachian tube, then they come back 2 years later with patulous eustachian symptoms that can go back and forth sometimes. And so these two are a bit blurry, really. So let's look at the anatomy and physiology of eustachian tube. So this is what you see when you scope the ear, and this is a schematic of it, of what really is going on. So this is the cartilage would sit over there, and then there's the levator veli palatini and the tensor veli palatini on the lateral surface here. So essentially, when you swallow, this tenses, and the levator elevates, that tenses, the cartilage rotates up, and you get some opening. So it's a coordination of many muscles. So it's a very complicated movement. So it's very difficult to appreciate this for endoscopy alone. I've endoscoped many of these people, and it's very difficult to find what's wrong with these patients who have these patulous eustachian tube symptoms. This is my eustachian tube using a special high-resolution dynamic CT. This is me valsalving. You can look at this is air. This is air window. This is me valsalving. You can see the eustachian tube starts to open, and there's a little bolus of air that goes through when I valsalve it. That's how big the eustachian tube is. That little tiny area is where you have problems with either hypofunction or patulousness. That is very hard to operate on from the eustachian tube side or from this side, because it's right in the middle here. So the valve is not at the opening; it's way up in the middle here, between the opening and the bony canal. So the other thing you need to know is that when you speak, sound enters your ear through the eustachian tube. It causes exactly the same stapes movement as if it comes from the external ear canal. So this is some temporal bone studies that we did. We look at the malleus and stapes vibrations when we produce the same sound in the external ear canal, or we put the same sound pressure in the middle ear. It causes exactly the same movement. So the ear doesn't care whether the sound come up through the eustachian tube or if it came up through the external ear canal. It will respond the same way. Also, the size of the mastoid makes a difference. I'm not sure why it keeps advancing itself, maybe something to do with my presentation. But the size of the mastoid, this is the sound pressure level measured through a standard sound entered in the ear canal in cadaveric temporal bones. And if you do a mastoidectomy or change the volume, it changes the sound pressure level, particularly at low frequencies. So the size of the mastoid also makes a difference to how much autophony you're going to hear. So, typical signs and symptoms of patulous eustachian tube. There's an overlap, as I say. So I'm going to tell you that patulous eustachian tube can cause serious otitis media by sniffing-induced negative pressure. We'll talk about that. Patients can go from one type to the other. They can go from hypofunction, I don't know why it keeps moving, to patulousness, and inflammation can stent the eustachian tube open. We see them going back and forth. It may be a continuum. So typical history, people who come to see you, they often have a pressure in the ear, which is very nonspecific. So a lot of times people think pressure in the ear, this keeps advancing. People think pressure in the ear is causing negative pressure. It can be from patulous eustachian tube too. So they can have echoing of the ear. So hang on, there's something missing here. Okay, so when you do a laryngotomy and it relieves the pressure, it doesn't mean they had obstructive symptoms. It could have been patulous, because that will also relieve patulous eustachian tube symptoms many times. They have echoing of the ear, autophony, and I can tell you this, a really good trick is if you put your finger in the ear and say 1, 2, 3, have them say 1, 2, 3, the occlusion effect is exactly like a patulous eustachian tube. So you put your finger in the ear, get them to say 1, 2, 3, they recognize that as exactly what I have at home, because many times they won't see you when they have the symptoms. They will be in between symptoms. It comes and goes. So it's exactly like the occlusion effect. It's a low frequency enhancement. They can hear their own breathing. And lying down makes it better. So sometimes you have to do that in the clinic, make them lie down, and they won't believe you, but the symptoms will go away. But that's very similar to superior canal dehiscence, so you have to be careful that you don't confuse this with superior canal dehiscence, which also causes echoing in the ear. So, and often, some people will find a place on the neck they can press to make the symptoms go away, and you can do that in the clinic as well. So these are things you can do in the, and often they're teachers or voice users like professors, because they use their voice all the time, and this passionlessness drives them crazy. So typical findings. So, I don't know why it's advanced, but anyway, the typical findings, so if their eardrum moves respiration, that's easy. That's the easy diagnosis. You know, those are the ones that are very easy to spot, because you get them to pinch one nose, side of your nose, and they breathe in and out through the other side. That accentuates the negative pressure in the nasopharynx, and the eardrums moves in and out. Those are the easy ones. So pressing on the neck, you can usually find a spot. You get them to say 1, 2, 3, 1, 2, 3, 1, 2, 3. Press on the neck, and it gets better. So you can see that. Lying down, especially if you raise their legs, will often make the symptoms go away. Sometimes you have to raise their legs to get the venous congestion to go on. Endoscopy, I found very non-useful, despite Dennis Poe's many publications that he can see wasting of Osterman's fat pad. I'm not as good. I have not been found to be a reliable indicator in my hands of patch eustachian tube. So this is what I'm going to talk about today, is that some of these patients don't have patch eustachian tube because they have an opening of the eustachian tube. They have it because they have a resonance in the middle ear. So one of the things you can do also is you can put cream on the ear and see if the symptoms go away. And I'll show you how to do that. So you just take some cream with a syringe, you put it on the eardrum. If they magically get better, that's a very big clue. You can have them, if sometimes they don't have patch eustachian when they come and see you, but the exercise can bring it on, so you can get them to go up and down the stool, exercise, have them come back, and sometimes that will bring on the symptoms, so you can test it. This wasn't working when I was okay, so this is a typical patch eustachian tube. Media not found. Anyway, I'll show you one a bit later. This is early, and the whole eardrum is moving in and out. This is a bit later on, and you can see later on, this eardrum becomes quite floppy. So these patients, you can see it moving respiration. So this is moving respiration. These are similar to ones that Saji showed you. This eardrum becomes quite floppy with time. So we have all these classic triggers. People who have radiotherapy, hormone pregnancy. This is really annoying. Nasal decongestants, fatigue. Most, in our experience, don't have any trigger factors. They don't have any of these trigger factors. The majority are completely idiopathic. So we have not found that to be a big classic determinant in patients that we see. So I think there's this concept of speech hyperresonance of the eustachian tube disorder. It's not truly an open eustachian tube, but they're hearing their voice hyperresonant in the ear. So many symptoms, they have all the same symptoms of true patch eustachian tube, but there's no true continuous air connection between the nasopharynx and the middle ear. And why do I say that? Because if there was a connection between the nasopharynx and the middle ear, then the eardrum would move with respiration because it's very floppy. And it's a very good pressure sensor because it's so floppy. But this patient's eardrum does not move, but they have all the symptoms of patch eustachian tube. They have their voice echoing, drives them nuts, they hear their respiration, etc. So there's either there's some low impedance pathway for acoustic energy from nose to the middle ear, or there's some kind of resonant cavity which is resonating with their voice in speech frequency. So there's many mechanisms why this can happen. There could be a resonance because many of these patients have had multiple ear infections in childhood, so they have a small mastoid cavity. So they may have a very hyperresonant mastoid because it's small. They have a floppy eardrum here because of recurrent ear infections and from the eardrum moving in and out. So they've set up a resonant cavity with a very low compliance eardrum and a small volume, and that might set up a resonant cavity. It could be because there's resonance of the cartilage itself. It could be because there's an air pocket here that's resonating. Or it could be that it's truly open, but there's some kind of fibrous band across it, so the respiration does not move the eardrum. But these patients have all the same symptoms of patch eustachian tube. So let's look at tympanic membrane role in all this. So I said many of these patients have had a long history of ear disease, and they've thinned atrophic segments of tympanic membrane. I've been sniffing these in and out, and I'll talk about this. There's no movement of tympanic membrane with forced inspiration and expiration, though, and I'm going to talk about the role of sniffing in these things. So this is an important concept we have to think about. It's the concept of failure of closing. So me and you, when we sniff, our ear does not move in. Our eardrum will not go in when we sniff. But these patients, it will. They've actually got a failure of closing with negative pressure. So sniffing is a way to relieve the symptoms of patulous eustachian tube because it may close the eustachian tube. My own thought is that it sucks in the eardrum, which stops it resonating with their own voice. So they have a resonant cavity, but when they sniff, it sucks the eardrum in, and it stops their voice from resonating. And often that's learned in childhood. So they start in childhood. So that can lead to negative pressure, it can lead to retraction pockets, serous otitis media, cholesteatoma. And this is a person, for instance, here's an early sniffer. So when you get them Valsalva, they can pop the ear out, and then you get them to sniff, and they can pop it back in again. They can do that repeatedly. And if you see them later, this becomes very, very floppy. Okay, this is before Valsalva, after. So now this is a later patient. You can see the ballooning of Valsalva goes back in. So, and this is the other side of this patient. So they've actually broken down the eardrum. So sniffing is much more common in cholesteatoma ears and in chronic suppurative otitis media ears than in normal patients. We've done studies on this too. And so it may be a contributor to cholesteatoma. So watch out for sniffers. So I call these popper sniffers. They pop their ears to try and make it just right, then they sniff everything back in because it's too loud. And sometimes they present with TM perforations. So one of the things you have to watch out for is if you fix their TM perforation, they may get all the symptoms back because the hole is venting their voice. So watch out if you fix the TM perforation in these patients. It starts in childhood. They don't even know they're doing it. You see them pop, and then they'll sniff in immediately because they're trying to get rid of that hyperresonance. So, and then often you see the floppy TM when you look at it. So audiometrically, well, if you have classic patulous eustachian tube and you get them to do the respiration, do reflex decay, you'll see the tympanogram move up and down, right, with respiration. And if you get them to hold one side of their nose and breathe in out to the other side, it'll accentuate it, and you'll get this deep changes on the tympanogram with reflex decay. And this is an actual tympanogram with nasal forced ventilation. You can see this very typical pattern. And this is quite a sensitive test for patients who have true patulous eustachian tube. But most of these patients don't have this. They're negative on this. But they have all the symptoms of patulous eustachian tube. What you will see is a AD-type tympanogram, because they have a very floppy compliant TM. You look at the tympanogram, they have a very deep segment on the tympanogram. So we've tried various things to diagnose this. We did nasal audiometry, where we put a sound in the ear, and we see how much we can mask the hearing through the nose. So that should pick up a low impedance pathway, because we can see how much sound gets to the ear. And we found that in the low frequencies there's a difference, but it's not very diagnostic. So we threw this away. This is published in Patulous and Bance. We spent years doing this test, and it's not actually very good, so don't bother. We've done some new acoustic tests of eustachian function, which I won't talk about here. That's a whole other talk. And if you look at these patients with medical treatment, nothing works for them. Head down, hydration. We try all this thing. You can put on weight. You can wear a tight tie. Saline nose. That actually works for some people. A tight tie does work if you just want to limit the congestion for a time. So I have a lawyer who does that every time he has a court case. Nasal saline cases, swimming in chlorinated pools, craniofacial therapy, yoga. We've tried all of these without any great success. These are all the ones that have been reported. Patulent. These are herbal teas. You can even bury anything. It all seems very voodoo-like. There's no good medical treatment that we've found for this kind of condition. So we've tried injectables. So I've tried injecting Teflon, gel foam, fat, Perlane. These are patients that truly have movement of TM. I'm not going to talk about any of this stuff. I've done a whole bunch of this kind of surgery. This is me doing a Perlane injection, and we go through a nasopharynx, stent the eustachian tube open, and we try and inject the Perlane and plump up the medial and lateral walls of the eustachian tube. And usually you try and get the Optimus fat pad, inject the Perlane in there, and I did about, forget how many of these I did, quite a few. And it didn't help these patients who don't have movement of the tympanic membrane very much. So nice and plump. But they come back at 2 weeks. So this is about 5 years ago. I've done about 20 now. About 1/3 had long-term success, 1/3 had no success, and 1/3 no benefit after 2 weeks. So it was not very useful. I did radius injections, very difficult in the right place. I've tried permanent obstructions, cartilage for more patients who have more movement, and I'm not going to talk about that. So myringotomy works sometimes, because what myringotomy does, it vents the low frequency, so the voice is coming up to the eardrum. If you make a hole in the eardrum, then it vents out the low frequencies because the myringotomy is a low frequency shunt. So sometimes that works. Sometimes it makes things worse though, because they hear their breathing. So I want to talk about a new approach, which is dealing with these atrophic TM segments. So when you get somebody like this, and they have all the symptoms patulous eustachian tube, but the eardrum does not move with respiration, then we published in 2012, you can find it in Journal of Otolaryngology, we started mass loading the ear with clay, blue tack, basically, poster clay. We did a study on some of these patients, these symptoms of classic patulous eustachian tube, and in fact, we had pretty good results. The echoing, breathing, plugged, environmental sniffing all got better in many of these patients. So I was bringing them back every couple of weeks. It only lasted about 2 weeks to 2 months, and then I started using stereo strips, and that works a bit longer. And then we started using. So then I wanted to do something more permanent. So in these patients, these patients who have a floppy segment, the way to test them is you just put clotridone cream in here, which is a white cream. I use it because it's white and it comes out easily out of a syringe. So you load the posterior superior quadrant, and I love this cream because you can fix holes with it. You can see if the perforation is going to be fixed. And this magically makes all their symptoms go away. If it doesn't, I will not operate on them. But if it does magically make their symptoms go away completely, almost, then I'll consider surgery on these patients. And I've done laser myringoplasty to stiffen up the TM. I'm not going to bother with the video. I've done cartilage tympanoplasties. I'm just going to tell you the comparison. So we did cartilage tympanoplasty, I think it's 14 versus 14. This is published in 2014. We compared KTP myringoplasty of that floppy segment versus cartilage tympanoplasty. Cartilage tympanoplasty was actually pretty successful in about 70% of patients in getting rid of their symptoms without causing any hearing loss. KTP stiffening was very variable. Some got worse, some got better, mostly got better, but not nearly as effective as reducing symptoms, which are all decreasing symptoms as cartilage tympanoplasty. Here's another slide showing the percentage reduction in these symptoms with KTP on average versus cartilage tympanoplasty. So here's a patient who had cartilage tympanoplasty. He can tell you a little bit about what his symptoms were. So tell me about your symptoms in your right ear before and after the cartilage replacement.
Before the surgery, my ear would plug frequently throughout the day, and I would be like talking. I'd hear my own voice in my head, and I'd have to sniff to relieve the plugging, and that worked. But I had frequently throughout the day, it would come several times, and very annoying. After the surgery, it's been excellent. I've not had it hasn't taken it away 100%, but like 90%. So I'm very pleased, and there's been no plugging in. When it does, it's gone very quickly. So
Yeah. Anyway, she's very happy. Actually, that was a couple of years ago. Some of the symptoms came back slightly, about 10-15% about a year ago. She's only 80% happy now, but she still was pretty happy at the time. So recap, negative middle ear pressure can be from obstructive or patulous eustachian pathology with sniffing, so don't necessarily think that it's only obstructive. Pressure in the ears can be from both patulous eustachian tube, and relief doesn't mean it's obstructive. It could be patulous eustachian tube. Watch out for sniffing-induced suppression of patulous eustachian symptoms. These people will be popping and sniffing, and you watch them, and don't confuse the superior canal dehiscent. Anyway, that's basically it. If it's a floppy segment, try mass loading. If that helps, think about stereo strip or blue tack. If that helps, think about cartilage replacement. It's not as effective if the whole TM is moving, so it's only for those patients where the TM is not moving and there's a floppy segment, and they magically get better with the cream loading. Okay, that's great. Thank you.
I'm sure you have lots of questions, but we can keep on to 2 free questions. Saji, please.
Right. Quick one. Why do you think that with the patulous eustachian tube, the patient will present these symptoms, and with a ventilation tube, they do not? Second, have you done the cartilage tympanoplasty in patients with near normal tympanic membranes and symptoms? And third, when you do the cartilage tympanoplasty, you insert the ventilation tube at the same time?
So take them in reverse order. That's the way I remember them. So I don't put the ventilation tube at the same time. No, just cartilage tympanoplasty. In terms of, have I done it in patients who have had typical symptoms of eardrum moving? I have done it in one patient, only got about 20-30% improvement. So I will not do it in those patients anymore. I will only do it in patients who completely get relief with the cream loading on a floppy segment. It may work, but I'm just very nervous to take a normal hearing ear and operate on it. And what was the first question, the ventilation tube?
Why do you have this sensation when you have a patulous eustachian tube and not with a ventilation tube in position, for example?
Well, the ventilation tube actually relieves it a lot of times because it vents at the low frequencies. And often, when you do this is mainly accentuating frequencies under 1,000 hertz. So the ventilation tube often will vent those frequencies out. So it actually, most